Hi, I'm Dr. Saluda from Los Angeles. I'd like to say that I am honored to be here. I thank you very much for the invitation to talk. I think there might have been a miscommunication on which lecture to bring. This is not a video lecture. It is a PowerPoint lecture, but it's a good lecture, and it's basic. It's probably for juniors. It's about component positioning and ligament balancing in total knee arthroplasty. These are my disclosures. What are the principles guiding component positioning? Well, you want to restore the mechanical alignment. You also want to preserve or restore the joint line. You want to distribute the contact stresses symmetrically. You also want to achieve reproducibility, balance soft tissues, and you want to optimize the functional outcome. So in my cases, for femoral alignment, I prefer an intermediary guide. I insert my AM guide approximately 1 centimeter anterior to the PCL origin. For my distal femoral cut, I usually cut about 9 to 11 millimeters, corresponding to the thickness of the femoral component and the degree of contracture. You have to pay attention to your sources of error. So if you have an entry hole malposition, you'll have a valgus error if it's too lateral. Also, if you have an oversized canal, your IM rod toggles, and you'll get 1 to 2 degrees of varus to valgus error. For my proximal tibial osteotomy, I usually cut approximately 8 to 9 millimeters below the least compromised cartilage, and approximately 3 to 5 degrees of slope. My goal is to have a polyethylene approximately 9 to 11 millimeters. For my tibial alignment, I prefer an extramedullary guide versus an intermedullary rod, which would give you decreased accuracy with bowing and valgus knees. I usually cut perpendicular to mechanical axis of the tibia. I reference off the tibial plateau center, the shaft axis, and the center of the ankle, noting that the center of the ankle is 3 to 5 millimeters medial to the midpoint between the malleoli. Your sources of error here, you do have to pay attention. Even a small error can give you deformity. If the alignment rod is pointing towards the lateral malleolus, it leads to a varus, while pointing towards medial, it leads to valgus. For my femoral component rotation, I use a measured resection. I usually cut 3 degrees of external rotation off the posterior femoral chondral axis in varus knees. I do a double check and make sure that it's parallel to the transepicondylar axis, and then I also do a triple check and make sure it's perpendicular to Whiteside's line. I try not to screw this up. For femoral component rotation and flexion, the normal lateral laxity of ligamentous structures produces a trapezoidal flexion gap. As a result, you need some external rotation of the femur to avoid flexion imbalance and patellofemoral problems. Usually, you'll perform an asymmetric resection of bone from the posterior femoral condyles as a result. Proper rotation contributes to a rectangular flexion gap, which gives you balance and stability in flexion, improved flexion, decreased need for release, less medial tibial pain, and good patellar tracking. In a valgus knee, there's usually a posterolateral condyle deficiency. If your feet on the guide rest on the host bone, you'll be internally rotated. So you want to pull the 1 foot off the host bone or dial in the rotation that the system allows. In rotational positioning of the tibial component, the landmarks include anterior and posterior cut surface of the tibia, tibial tubercle, and ankle mortise. With the knee flexed, the midpoint of the component should be in line with the medial 1/3 of your tibial tubercle. You use a suspended alignment rod to check. With the knee extended, you arrange the knee, you observe the patellar tracking, and you allow the tibial component to find its correct position. You want to avoid excessive internal rotation, which will give you lateral patellar tracking, increased wear, and possible patellar subluxation. In sagittal plane positioning, the femoral component I usually place in 3 to 4 degrees of flexion, which is usually built into the cutting guides. This avoids notching of the anterior cortex and conforms the natural 4-degree bow of the distal femur. In the tibial component, I usually aim for 0 to 5 degrees of posterior slope. Depending on anatomy, more slope allows for a larger flexion gap. For releases, for mild varus deformity, I usually do a deep MCL release. I usually release the capsule and remove osteophytes. For more severe varus deformity, then we have more options, a deep and superficial MCL release of semimembranosus, PCL, as well as a pens adserine insertion. For valgus deformity, I routinely release the lateral tibial capsule, remove osteophytes, and release the PCL. If tight extension, then I'll do IT band perforations. If tight extension and flexion, popliteus and LCL release. If tight inflection, popliteus, LCL, and posterior lateral corner releases. Tracking should be your final check. It's a good indicator of appropriate component positioning, aided by external rotation of femoral component, appropriate rotation of tibial component, and good positioning reduces need for lateral retinacular release to less than 5 to 10%. In summary, the component positioning is a critical part of successful total knee arthroplasty. To restore your mechanical axis, you should never place the femoral component internal rotation, never place tibial component internal rotation, and patellar tracking is a good indicator of overall proper positioning. The end.
Thank you, Jonathan. I would now invite Ketan Shah to talk on bilateral knee arthroplasty in Wincept deformity. Ketan is around? I think we'll call the next speaker Anuj Malhotra to talk on pain management in knee arthroplasty, current trends.
Thank you, organizers, for EAC and respected chairpersons. So since morning, we have been talking about pain. Patients come to us for pain, so I think this would be of some help. So why do we need a pain management? Despite all the advances of the surgeries, we find that still patients complain of pain post-operatively very commonly, and it can delay the recovery and mobility, leading to the poor outcomes. So the patient perception of pain has shown to affect the surgical outcomes, overall surgical experience, including their perception for the treating orthopedic surgeon. So it is not just pain. Pain itself carries the risk of cardiac, pulmonary, GI complications, as we all know. So these are the neurogenic and inflammatory pathways by which the patient perceives pain, not going into the details. So the current guidelines for the pain management in total knee arthroplasty has patient education, the administration of preemptive analgesia, then intraoperative analgesias of epidural spinal peripheral nerve blocks, the periarticular injections, the PCAs, and oral analgesics. So these are used sequentially or in combinations to help pain relief. So when we talk of preoperative pain management, what does patient want out of you? So the first thing patient says is, मेरे को दर्द में आराम होना चाहिए, मेरा full function आना चाहिए, मेरा कोई काम नहीं रुकना चाहिए. What are the side effects of surgery? And how quick I will recover and I'll come back to the normal day-to-day life. So the pre-operative counseling with the patient is very important. Interviews, there can be presentation sessions, videos of your earlier operated patients, those who are talking in detail. So they should be shown to the patient so that the allay of anxiety is there. So preoperative education has found to be very helpful in increasing the patient satisfaction, shortening the hospitalizations, and shortening rehabilitation periods as well. So there are various modes for preemptive multimodal analgesias, NSAIDs, opioids, all have been tried, and they all have been found to be very useful in decreasing the hyperexcitability of the nerves and the pain. So the medications have opioids, the medications have COX-2s, the medications have been pregabalin, gabapentin. They all have been shown to decrease post-operative analgesics requirement. So the next upcoming trend is cryoneurolysis. In this, we have a probe, and there is an inner cannula inside from which there is liquid nitrogen, NO2 or carbon dioxide is injected, and somewhere around 0 to minus 10 degrees. So it helps in decreasing the nerve impulse conduction and excitability of the nerve, but it has to be done 5 days prior for the cutaneous nerves. It is kind of a nerve block, and it is temporary. The effect of this is somewhere around 15 days. So the cryoneurolysis is performed by the device, which treats the nerves in lower temperatures. And these are the nerves which are commonly deactivated, that is infrapatellar branch of the saphenous nerve and the anterior femoral cutaneous nerve branch. Coming to the intraoperative period, so regional anesthesia, we all know, have been very useful. Spinal epidural is gold standard until and unless it is contraindicated. So it helps in surgery as well. So the peripheral nerve blocks now is being frequently used in all the centers, and this has a very remarkable result in early physio, early standing of the patient, Definitely the site is important. More distal nerve block is, the better muscle sparing, and the patient can be weight bearing immediately. This has a very drastic improvement. So the peripheral nerve blocks have been shown, if given for a longer terms, they can cause muscle weakness, increase risk of falling, and post-op rehab as well. Then comes periarticular injections, most commonly used as cocktails. Many centers have been using it. I personally don't use it. So there are various medicines like bupivacaine or ropivacaine with morphine, with ketorolac, triamcinolone, or various antibiotics. And they have been shown to the use of opioids have reduced with this use of periarticular injections commonly. So the periarticular multimodal drug injections significantly decrease the pain. But there sometimes when the half-life goes off after 6 to 8 hours, the patient can have a rebound pain, and the patient should be educated about it. So the most commonly used drugs are local anesthetics like bupivacaine, ropivacaine, morphine or ketorolac, clonidine. For longer acting, epinephrine is also added. So the liposomal bupivacaine, again, a latest trend, not very commonly available in India because of cost constraints. Also, people are not using it, but it is a very good peripheral nerve block for longer duration of actions. So there are papers which have shown that the periarticular injections are very helpful in this. Coming to the post-operative regime, the patient control anesthesia is very helpful, and the IV PCAs have been tried, and they are gold standards in many centers and in my center as well. The patient just needs to click. The multimodal oral pain regimes is using different drugs, using acetaminophen, using diclofenac, using opioids, anything, and in a smaller doses. So if you use multiple drugs, it is like more effective and the lesser side effects. So the conclusion goes that if you want to provide a better surgical outcome in terms of pain relief, it has to be multimodal. You know, the systemic complications are less and the rehabilitation is early. Thank you.
Thank you, Anuj. Now we invite Dr. Kiran Karat, who will speak on DVT prophylaxis in TKA. Current
Kiran
thoughts.
is not there, so Gurinder Bedi will
So,
talk
Gurinder,
on the
please.
same topic.
Hi guys, so this is a stand-in show for Kiran. I'm neither as handsome nor as smart as Kiran, but hopefully you'll make do with me today. So very quickly, this has been handed over to me in the afternoon, so excuse my misdemeanors for this. So how many of you believe that DVT is not an issue after hip replacement or knee replacement? Okay, how many of you are not routinely giving anticoags after surgery? So only one person. Okay, my job
Gurinder, can you specify which anticoags?
Okay, so let's go on to how many of you are not doing, let me rephrase that. How many of you are not doing prolonged anticoagulation after replacement? Prolonged is 2 weeks at least. So do I take it you're doing an early Clexane kind of a stuff and nothing else after that? Is that the same for you? So you no believe in oral anticoags or something? Is that something? I think everybody's using low molecular
we use
beta.
aspirin.
Oh, sorry. Aspirin is included in that. Are you giving aspirin at all? No. Are you giving aspirin at all? So one person is giving aspirin.
I give aspirin.
Aspirin, okay. So here we go. So very quickly, I think all of you know the signs, symptoms of DVT, so not going to go into it. Is it a problem? Is it not a problem? And more it looks as if maybe we've been sort of, blinded by thinking it's a Western problem. In all probability, the work was tried holds true, and it should be a problem. Why do we not see it as well? Most likely because we are not picking it up, our eyes are not open to it, but I'm sure it does exist. High incidence because you got everything going on which can make it into a big problem. So whichever literature you look at it, it should really be a problem. Indian Journal of IJO paper, 72% in total knees, 42% in total hips. This is if you don't do anything at all. So another paper which looked at, is it not an Asian problem? But again, look, they have a significant percentage of Indian population in this, and they thought the literature was showing that same percentage of Asian population has it. And this is a paper which actually looked at subgroup of different populations, which include over 600 Indian patients, and the incidence of DVT remains the same in this. We are comparable to what they do in Singapore, Orientals, or whichever way category you look at. Are we not investigating it enough? So the investigation, when you look at it, The contrast venography stands out as the gold standard, so you need to really weigh it up against. I'm sure none of you is going to do it routinely, but if you're not going to do it routinely, the compressive ultrasonography is what I think most of you would end up doing. And again, so not a bad sensitivity or specificity, but do the compression one rather than just the ultrasound pattern. This. A lot of people checking on D dimers. D dimers is very sensitive but very non-specific. The new thing could be an MR related DVT pickup, but that's a different story. So most of us are going to do a compression ultrasound scanning. The problem with that is it's very operator dependent. So you really need to be sure that you got the right guy who keeps on doing it. And the problem comes, it will not pick up the old and the new clots. And again, if you have a significant edema or significant obesity, it's going to miss it out. So it's less accurate in small vessels, especially when you come to pelvis and all, it's not very accurate at all. What about VQ scan? So ultimately the goal of DVT prophylaxis has to be to prevent pulmonary embolism. So VQ stands out as a standalone modality, excellent for picking up any pulmonary embolism. You can do a CT angiography or an MR angiography as well. So they're fairly good if you really want to pick it up. D-dimer, again, sensitivity, specificity problem. So be sure if you're going to use it, you know what it entails. So this is some of the criteria that people are looking at when they talk about which is a high-grade category for diagnosing or suspecting. So all these things, I think I'm fairly confident you're sure about. So the test, as I said, invasive venography is the gold standard, but you cannot really recommend it for everyone. A radionuclide ascending venography with perfusion lung scan, possibly a wonderful tool if you really want to be sure that you don't miss out, if you're not going to miss anything out. So we've already looked at the idea that it's actually a pan-world problem, not just an Asian population. The controversy starts when the chest physicians and the American Academy sit down together. Actually, they don't sit down together. That's a real problem. So the chest physicians are pedantic about you need to anticoagulate everyone, and the American Academy is slightly ambivalent on it. But more and more, the recent recommendations are all coming towards routinely actually giving some sort of a prophylaxis. If you're a believer in selective one, these are the things which should really make you think that you really should be thinking about this population. So the risk stratification is what a lot of people are doing. They pick up, well, it's just like a patella. It's a toss of a coin and say, I mean, should I replace the patella? Should I not replace the patella? But this is what people look at. So if you have an elderly person, especially if you have a history of pulmonary embolism, history of a thrombus, history of varicose veins, a blood disorder in the family, or any of these things about, being in the bed previously, having a car separately. So lots of these things can actually give you an idea. You really should be looking at selectively giving even if you're a non-believer. So we're talking about things like obesity, bed rest, other aspects, and there are lots of scoring systems. You can have a look at the scoring system which you can use to find out what you need to do. So this was a great study, printed in the Journal of Arthroplasty, which looked at two things. In one group, they did a routine anticoagulation versus a risk selective one in which they did it selectively only. And what they showed was that your wound complication rate was higher if you actually give it routinely to everybody. That's a 8.4% versus a 4.4%. So almost double the rate if you give it to everybody. The other thing that they showed was they were twice as likely to, just a reiteration, twice as likely to show and superficial rate of infection and deep rate of infection in the ones in which you're giving it to everybody is actually coming out to be a higher one. So this is a fairly decent study published in a good journal, so worth noting. So, but there's not one method which you can use. In Australia, everybody uses low molecular weight, but there's no doubt that if you're a believer in regional anesthesia, which most of us are going to be, you are going to have at least some lesser chances of getting a DVT. And if you're going to put an epidural catheter, you got to remember when to give a dose before and how soon after you should not be given another dose. So aspirin used almost routinely in a lot of other centers. American Academy is now recommending 6 weeks, 6 weeks thing. The thing that a lot of people are using now is a factor 10A inhibitor, both for its increase in this thing. Fondaparinux was one thing which came out, sold by the name of Erixtra, possibly has a higher chance of bleeding. But I think what a lot of people have shifted to is a rivaroxaban and apixaban. One is once a day, one is twice a day. If you have a twice a day, you're lesser half-life. So if you have to go in again for whatever reason, or you want to stop it, maybe apixaban actually scores slightly better. Dabigatran is the other one that people are talking about, but I think in India most people will be using a rivaroxaban or a apixaban. Please do not forget the mechanical prophylaxis. The new kid in town is the Gecko one, which has a electric stimulant which actually keeps on giving a current and keeps on stimulating the calf muscles. Whatever you do, the consensus point is regional anesthesia works, early mobilization works. I think, in my opinion, you should use some prophylaxis and maybe combine 2 or 3 different modalities. Okay, but there is no doubt that nobody's actually shown that the incidence of pulmonary embolism has actually decreased, especially fatal pulmonary embolism, whether you use it or you don't use it. So that's something which is going to stand against it. But I think you should not go with the idea that it's not an Indian problem at all, but be wary of some of the other side effects which come.
Thank you,
so much.
Gurinder. Well, I think there is a point why fatal PE has not decreased, because PE, most of it depends on the surgical trauma.
Quite right.
And DVT depends on the post-op stasis. So whatever you are doing post-op will help post-op stasis only, will not undo the surgical trauma that you did during surgery. So probably that is the primary cause why PE rate is not affected, whether or not you
That's
do
right.
any
Most likely, but
yes.
there is no doubt that if you use it, you will decrease the incidence of DV,
Yes.
but not PE.
Thank you so much. Can we now call Amit Pispati? Is he around? Yeah. Amit will talk on getting cup right. Thank you.
Thank you, Dr. Manoj, for having me here. So we all are riding the uncemented wave currently. I'm sure you'd all agree. And it's both patients as well as surgeons who are doing that simply because it's easy to do. The cups and stems are reproducible with excellent long-term results. What's also contributed is an easy technique, good implant design, good fixation and results, excellent bearing technology, and predictable pain relief after the surgery. So it's important we know our anatomy, but we must anticipate problems, look for solutions. Therefore, we need to over-prepare and go with the flow. But first things first. What's important is you must plan, because failing to plan is planning to fail. You've got to do good pre-op planning, decide the components and the bearing, and it's important to do pre-op templating. Consider in the pre-op templating the acetabular inclination, which is the abduction, and alpha, the acetabular version also. Make sure you're going to plan to get it right. You've got to reproduce the hip geometry, which means the offset, the center of rotation, and eventually get your leg lengths right. The templating is useful because it helps make the surgeon think 3D, helps the team plan special instruments if required, ensures adequate implant inventory, and can help predict difficult intraoperative situations which you might not anticipate otherwise. In a difficult primary, which you can then predict, you've got to have a big inventory, over-prepare, plan your bailout options, hedge your bets, involve different companies, and certainly check your instrumentation a day prior. So you've got to learn to expect the unexpected. Positioning and approach, if you're doing it with the patient in a lateral position, as most of us do, these are sort of hip supports that I tend to prefer because you can pin the patient down comfortably, the abdomen is left fully free, and try as you might, you will definitely not be able to shift the patient. Make sure you have adequate hypotensive anesthetic, a good surgical exposure. That's the start to getting your cup right. And you need to position your cup accurately because that helps to reduce dislocation, reduce the wear, avoid psoas impingement, and certainly helps to obtain a good impingement-free range of movement. If you don't get this right, there are going to be problems because inclination more than 60 degrees means increased wear, decreased adduction and rotations. Inclination less than 40 degrees means you have less flexion and abduction, and excessive anteversion not only increases dislocation, but means increased flexion and also a decreased extension. So there's numerous factors now to be taken into account. In terms of landmarks, you need a good exposure, so you need to take the soft tissue into account, preferably the tal and occasionally the labrum if you're confused. There are bony landmarks such as the ischium, the sciatic notch, the inferior acetabular fovea. Often one takes into account a combination of all these factors to getting you down to the right orientation. So once you're down to the acetabulum, you scoop out the ligamentum teres and the other tissue, identify the teardrop and then the tal, and you remove the osteophytes as suitable, leave some osteophytes behind if required. Initially start by vertical or medial reaming, so you go straight down to the teardrop. So that's the vertical reaming. You don't have to do it always, but you do it when there's a good central osteophyte. And once you've seen that the teardrop has been well exposed, as shown in the patient over here, you can then proceed with appropriate reaming thereafter. So that's the teardrop well exposed. You then proceed to ream in the desired direction, maintaining 45 degrees of inclination and 10 to 20 degrees of antiversion as suitable for that given patient, and use the towel to determine the antiversion. Ream down to punctate bleeding, and once your reamer has a solid fit, you can proceed to a cup which is a millimeter or 2 bigger, again depending on the system that you're planning to use at the time. And that's showing the appropriate antiversion and also showing the appropriate inclination with the patient in the lateral position, and you leave just a millimeter or so of the anterior column or the anterior wall exposed, so you're just a touch over antiverted, and as this diagram would tend to show you. And with the trial in the given positions, there are different options which can show you if you are correct or wrong. In position C, you would decide that the component is correct. If excessive anterior wall were exposed, as in the diagram D, it would mean that you are over-antiverted. If excessive posterior wall were exposed, as in the diagram on the bottom right, it would mean that you are retroverted. Finally, do a stability check, make sure that you're in the safe zone, put in screws if required, and put in the definitive liner at the time. All that would make sure that you will minimize the chance of impingement and dislocation. So the take-home message at the end of this is uncomplicate, organize your thoughts. A job well planned is a job well done. Be liberal in ordering your inventory, comfort is priority, understand your mechanics, make sure that you position the cup accurately, remain cool and calculated. And of course, I have to say at the end, since you all taken the effort to come here at the meeting, stay hungry and stay foolish and keep coming here always. Thank you so much.
We have come to the end of this session. So if there is any question, so speakers would be happy to answer. Okay, so if there are no questions, so we close it here, and we thanks all the faculty members for their talks. Thank you.
Yeah, thank you. Now we are going to the last session.